in between the two episodes is called a status epilepticus. So whenever a question is given on status epilepticus, the first step is stabilizing the patient with ABC. The second step is you have to give lorazepam. Okay, lorazepam injection or midazolam injection is the one which is going to be preferred in the patient. Okay, preferred in the patient. And one more thing here is you have can give up to 3 doses of these drugs. Whenever the patient is not responding to it, the next step is you go for levetiracetam, or you can go for valproate, or you can go for phenytoin or phosphenotoin. If the patient is not responding to it, go next step, propofol or midas infusion. Okay, it's not just midas, it is infusion. If it is not responding, then the next step is go for phenobarbital or a pentobarbital coma. If the patient is not responding, go to IV anesthetic agents. If the patient is not responding, intubation. This is the sequence. So first ABC, then you give loraz or midas, then you go for levetiracetam, valproate, phenytoin or phosphenotoin. If the patient is not responding, go for propofol or midas infusion. If not responding, phenobarbital. If not responding, then ketamine. If not responding, intubation and mechanical ventilation. This is how you will approach a case of status epilepticus. So we'll go to the question here. A 50-year-old male presents with status epilepticus. Okay, he is a known case of seizure disorder. In emergency department, he is exhibiting persistent seizures like activity for 30 minutes. Following administration of 4 milligram of loraz, he had another episode of seizures. Temperature is high, blood pressure is high, heart rate is high, and respiratory rate is high. Oxygen saturation is 94%. What is the next or subsequent course of action in the care of this patient? What you will do? Yes? Okay. So whenever the first step they are asking, then you go for ABC. Then the second step, loraz or midas. Third step, levetiracetam, valproate, phenytoin, phosphenotoin. Okay, phosphenotoin. The next step, infusion, then phenobarbital, then ketamine, then. So the answer here is in this sequence, if I'm going to fit ABC is done, this is done. So the next step is levetiracetam. So the answer here is levetiracetam. The answer here is levetiracetam. Yes. So the answer here is levetiracetam. Okay. So that will be the better option. Yeah, but see, this is not every time we don't know the exact calculation of time, right? We'll not know the exact calculation of time. Okay. So it is actually the steps which is important. Okay. Steps which is important. Okay. So even though time, so it is just an idea. Okay, not every time you'll follow the time, but the steps is very important. Okay, so based on the step you have to go. Okay, coming to the next discussion. The next discussion is going to be Creutzfeldt-Jakob disease. Okay, so what is this Creutzfeldt-Jakob disease? Okay, so there is going to be a prion protein. Okay, what is this prion protein? It is a DNA, RNA negative material. This DNA RNA negative material is going to be the prion protein, which is going to be in the form of alpha helix. Alpha helix. This alpha helical matter, due to mutation, it will be converted into beta pleated sheets. Beta pleated sheets. Whenever they are converted into beta pleated sheets, what is going to happen is it is going to be pathogenic, and this has the longest incubation period, which can be in years. Okay, and whenever it is going to have the longest incubation period, it is going to have a short duration of illness. Longest incubation period, shortest duration of illness. Okay, and if you take a biopsy, it is going to show spongiform encephalopathy. Spongiform encephalopathy. Okay, spongiform encephalopathy. Okay, and what are the features in this patient, or what is important? It can occur for lot of reasons in the form of sporadic, familial, and iatrogenic. 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 Okay, so whenever it is iatrogenic, it can because of anything as a procedure being done. It can be due to corneal grafts. It can be due to corneal grafts, or it can be any transplant organ. Transplant organ. Or it can be due to anything which is a recombinant technology product, like growth hormone, corneal grafts, dural grafts. Okay, dural grafts. Okay, all these can be iatrogenically inducing prions disease. Okay, what is the clinical feature? The clinical feature or the clue which can be given in your question is going to be patient has myoclonus, and this myoclonus is a characteristic myoclonus called startle myoclonus. Startle myoclonus, like a jerk. Okay, jerk. Okay, startle, like fear. And patient can have dementia, and patient can sometimes have psychosis feature. Psychotic behaviors can be seen. And if you do a CSF in this patient, the CSF will have a protein called protein 14.3.3, and the patient EEG is going to show a sharp triphasic waves. Okay, sharp triphasic waves. So there is going to be a sharp triphasic waves. Okay, this is called 1 hertz triphasic waves. Then the next thing is you can go for a MRI. MRI. The MRI will show striatal hyperintensities. Okay, and this striatal hyperintensities, which is going to be seen over the putamen as an hyperintensity, and that is called as hockey stick sign. Hockey stick sign, or it is also called pulvinar sign. Pulvinar sign. And along the cortex, you can see the ribboning, which is called cortical ribboning. So you get to see cortical ribboning, pulvinar sign, and hockey stick sign, right? Okay. So these are the MRI features you get to see. So coming to the question, a 51-year-old female with a 8-month history of neurological decline dies after a severe bout of aspiration pneumonia. Autopsy of her brain reveals extensive loss of granule cells in the cerebellum and other changes most obvious in the cerebellar cortex. Fine vacuoles, fine vacuoles give a spongiform appearance. No senile plaques are evident. The patient could have acquired this progressive disease through which means? Sexual intercourse, blood transfusion, consumption of raw fish, growth hormone replacement. So this is typically a case of prions disease. So the clue here is Spongiform appearance. 8 months history of neurological Am I audible now? Yeah. So yes. Now I think I'm audible. Yes. Yeah. Yeah. Okay. So the answer is growth hormone replacement. Okay. The answer is growth hormone replacement. Okay. So it is an iatrogenically induced prions disease. Prions disease. Okay. Coming to the next one. Okay. Which is going to be our Parkinson disease. Okay. If you take the wider term is Parkinsonism, and Parkinson's disease is idiopathic Parkinsonism. So why this Parkinsonism or Parkinson's disease occurs? It is going to be due to decrease in dopamine and increase in acetylcholine. Whenever there is a decrease in dopamine, the patient is going to have slowing of movements. Whenever there is an increase in acetylcholine, the patient is going to have tremors. Okay, so the cardinal features of your patient with Parkinson's disease is tremors. Okay, tremors. The tremors are resting tremors of frequency 4 to 6 hertz, pill rolling tremor if it is unilateral. Okay, if it is bilateral, then it is going to be the drum beating tremor. It is going to be the earliest feature of Parkinson's disease. Rigidity. Rigidity is of two types here, lead pipe and cogwheel rigidity. And akinesia or bradykinesia is the most characteristic feature. Okay, most characteristic feature. Okay, and next is postural instability. Postural instability, which is a late manifestation. Postural instability is a late manifestation of your patient with Parkinsonism. And what are the other features the patient can have? The patient is going to have a reduced arm swing. The patient is going to have a gait which is called as Festinian gait or shuffling gait. The patient will have stooped forward posture. And the patient is going to have a monotonous voice, which is going to have a inaudible sound, and that is called as hypomimia. 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 They will have a mask-like face. Okay, mask-like face, and they have freezing moments. When they walk like this, and they freeze, and they will turn. Okay, and they will also, because of postural instability, they will fall. That is called retropulsion or latropulsion, or propulsion can occur. Okay, so these features are the cardinal features of your patient with Parkinson's disease. Okay, Parkinson's disease. Now, the patient with Parkinson's disease has no definitive investigations. The treatment is going to be the replacement of dopamine. So how we are going to treat the patient, whether it is a motor predominant disease or a tremor predominant or a akinetic predominant disease or a tremor predominant disease. So you are going to give levodopa. Levodopa peripherally metabolized by dopa decarboxylase. For that reason, it is combined with carbidopa, and it is given. And the other drugs are the dopa metabolizers. There are something called COMT inhibitors and MAO-B inhibitors. Okay, so COMT inhibitors are going to be entacapone and tolcapone, and MAO inhibitors are going to be rasagiline and selegiline. Okay, rasagiline and selegiline. Now, we have dopamine receptor acting drugs. The dopamine receptor acting drugs are of two types. It can be a ergot derived or a non-ergot derived. If you take ergot derived, the ergot derived drugs have a lot of complication. They can cause vasospasm, so they can cause gangrene, and they can also cause valvular fibrosis. Valvular fibrosis. So you have to screen the patient with 2D echo every year. So here we have, there are few drugs here, which is going to be bromocriptine, cabergoline, pergolide. Non-ergot derived drugs, we have ropinirole, rotigotine, pramipexole, okay, and apomorphine. So on long run, whenever you give a drug like levodopa and the dopa requirement increases and you increase the levodopa, what will happen? The patient is going to face a phenomenon called on and off phenomenon, where whenever you increase the dose, there is going to be a peak dose dyskinesia. Peak dose dyskinesia. And it can go to such a level that the patient can have stiffening of the body. The patient body will turn like this, okay, and that is called Paisa syndrome. Paisa syndrome. So whenever you increase the dose, there is going to be a peak dose dyskinesia. How to prevent this? Okay, or if it is an emergency, how to tackle this? We have apomorphine. Okay, this apomorphine is given as a subcutaneous injection. Subcutaneous injection, and whenever you give this apomorphine as a subcutaneous injection, the patient will get relieved from the peak dose dyskinesia features, and because of this, this drug is called rescue drug. Rescue drug. Okay, and whenever it is a tremor predominant disease, you will prefer for anticholinergics, and the anticholinergic is going to be benzatropine, trihexyphenidyl, benzatropine, trihexyphenidyl. So this is the drugs used in treatment of patients with Parkinson's disease. And if the drug is not effective, you can also go for deep brain stimulation. Deep brain stimulation, DBS. Okay, DBS. So DBS, you stimulate the subthalamic nucleus or globus pallidus interna, okay, or even substantia nigra can be stimulated, okay. So coming to the question, a 70-year-old female has 1 year worsening of gait, right-handed tremors, rigidity. She is diagnosed with Parkinson's disease and improves dramatically with treatment. If her disease progress, the decrement in speech that would be expected would result in which of the following? Progressive inaudible speech, fluent aphasia, non-fluent aphasia, word salad. Yes, very good. The patient is going to develop what? Hypomimia. So there is going to be a progressively inaudible speech. Progressively inaudible speech. Okay, so that is going to be the answer. Coming to the next topic, which is going to be Parkinson plus syndrome. Parkinson plus syndrome. Okay, so what is this Parkinson plus syndrome? This Parkinson plus syndrome is unlike our Parkinson's disease. This is going to be bilateral, mostly symmetrical, seen in elderly patients. Poor response to levodopa. Okay, poor response to levodopa. And it has a poor prognosis. So now a question is being given. The patient has sudden onset stuttering progression, minimal tremor with lower limb affected more than upper limbs. Lower limbs affected much more than upper limbs, and that kind of gait, what they gait is called apraxic gait, or it is also called as Brun's apraxia. Now, this patient sudden onset stuttering. Stuttering means it is in a step ladder pattern. It is progressing in a step ladder pattern. Tuck, 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 worsening. Okay, within a short span. And if you go deeper, the patient will have history of TIA or stroke. So whenever you get a picture like this, okay, that is called as vascular dementia. Whenever this vascular dementia is a partial occlusion, you can also call this as Binswanger disease. Binswanger disease. Okay, Binswanger disease. Okay. Now the next question is given where the clues given are it is symmetrical younger patient taking dopamine antagonist or lithium. Okay. So whenever you have a young patient with Parkinson like feature, okay, then you have to think about either genetic cause or some miscellaneous cause. Okay. Now they have given here they are taking some dopamine antagonist which decreases the dopamine level. So it is going to be drug induced condition. Drug induced condition. What are the drugs commonly can cause? There are a lot of drugs, but what are the drugs commonly can cause for your exam? It is metoclopramide, olanzapine, risperidone, aripiprazole, and lithium. These are commonly used drugs. Okay, and there can be post-viral encephalitis Parkinson's that is named by a condition called von Economo disease. Von Economo disease. Sometimes it can occur following pesticide use. There is a pesticide MPTP. Okay, MPTP which is used as a pesticide. It can even occur following and trauma. Okay, trauma. You know the famous boxer was having this disease. Okay, and trauma, and it is called as punch drunk syndrome. So not only because of mutations or age related effects, it can also occur because of some miscellaneous causes. So this is going to be drug induced Parkinsonism. Drug induced Parkinsonism. Okay. So this is about your other causes. Coming to proper Parkinson plus. Okay. Whenever a patient with Parkinson like feature is given in a question and patient had marked postural hypotension where there is a BP fall of more than 30 millimeter of mercury, okay, and patient has sphincter disturbances also, and patient is going to be having cerebellar signs, then you have to have diagnosis as multiple system atrophy. In this multiple system atrophy, we have MSA P where Parkinson features are predominant. MSA P where Parkinson's features are predominant. Or MSA C, cerebellar features are predominant. And MSA ANS, that is autonomic nervous system features are predominant. That is also called as Scheidegger syndrome. Scheidegger syndrome. In MSA-C, this was a recent question. In MRI, you get to see a hyper intensity in the MRI in the cerebellum like this, and that is called as hot cross bun sign. Hot cross bun sign. Okay, hot cross bun sign. Okay, hot cross bun sign will be seen. Okay, so this is about the thing. Okay, and coming to the next one, where the patient is going to have early progressive dementia. Early progressive dementia, which is the patient will have Parkinson features, and within 12 months they develop dementia. Okay, that is one very, very important clue. Along with this clue, if they give visual hallucinations are present. Okay, or they give axial rigidity. Axial rigidity. Whenever this is given, you can think about Lewy body dementia. Lewy body dementia. Okay, Lewy body dementia. And in another question, if they are giving axial rigidity, and patient has vertical gaze palsy. In this vertical gaze palsy, it is a down gaze palsy. We saw previously up gaze palsy, but here it is down gaze palsy. Down gaze palsy. Along with the down gaze palsy, in your question they give the patient has square wave jerks. Square wave jerks. Okay, then the answer is going to be progressive supranuclear palsy, PSP, which is also called as Steele-Richardson syndrome. Steele-Richardson syndrome. So these clues, okay, so because of this down gaze palsy, the patient will have frequent falls. Whenever they give the word falls, then you can close your eyes and mark the answer as your progressive supranuclear palsy or Steele-Richardson syndrome. Progressive supranuclear palsy or Steele-Richardson syndrome. Now, another question is given where they have given certain clues. Okay, a patient has dementia. Dementia. So he is wacky and weird, wide gait, along with urinary incontinence. Whenever this feature is given, or wide gait is like ataxia is there, ataxic gait is there. Whenever this triad is given, it is called Hakim's triad. Excellent, Hakim's triad. Okay, and whenever there is a Hakim's triad, you have to think about normal pressure hydrocephalus. Normal pressure hydrocephalus. Okay, and here you do a test here called Miller-Fisher test. What is that test? You remove 30 ml of CSF, the patient will have a temporary improvement in the cognition. That is called Miller-Fisher test. So these are the Parkinson plus syndromes and Parkinson associated feature conditions which have to be learned very importantly. And I'll come to the question here. This is the MRI of a patient who had a history of multiple falls, and identify the sign that is not associated with the diagnosis. What should the answer here? You see the MRI. Which is not associated with this condition. Excellent, excellent. Okay, so here we have, see here, if you see closely here, what you see here? You see a bird there. What bird it is? It is a hummingbird. Okay, hummingbird. hummingbird sign or morning glory sign? Yes, this is going to be due to involvement of midbrain or midbrain atrophy. The patient is going to have a hummingbird sign. Along with this down gaze palsy, patient had slowing of movements and the patient is having square wave jerks. Then it is going to be your progressive supranuclear palsy, and the odd man out here is going to be predominant bladder and bowel disturbance. Whenever they give a predominant bowel and bladder disturbance in a Parkinson plus syndrome feature, then you have to think about MSA ANS. That is, the patient is having multisystem atrophy with ANS symptoms can be there. Okay, so this is going to be the 14th question, which is very, very important. Coming to the next one. Okay, so this is also a kind of dementia where the patient can present acutely or chronically. Acute or chronic. Whenever it is acute, the patient condition is reversible and it is characterized by three important things. Okay, so I you can use this mnemonic where patient can have global confusion, ophthalmoplegia, and the most common cranial nerve palsy is sixth cranial nerve palsy along with ataxia. You can use COAT or you can use GOA. Global confusion, ophthalmoplegia, sixth nerve, and ataxia, where the patient MRI is going to show hyperintensities in mammillary body and atrophy, okay, in the thalamus. So you think about hyperintensities in the mammillary body, then it is Wernicke's encephalopathy and it is acute and reversible. Whereas if it is irreversible, then it is Korsakoff psychosis, which is chronic, which is characterized by RAC, COTRAC, okay, COTRAC, retrograde amnesia, antegrade amnesia, confabulation. Confabulation is building up of stories. Okay, he builds up a stories with false memories. Okay, and that is the feature of Korsakoff psychosis. Korsakoff psychosis, and here also there is going to be involvement of mammillary body and dorsomedial thalamus. Mammillary body and dorsomedial thalamus. The treatment for both the condition is going to be thiamine. For both the condition, the treatment is going to be thiamine. Okay, so this is about your Wernicke's encephalopathy and Korsakoff psychosis. Just we'll go into a question. A 32-year-old man with alcoholism, use dating back to at least 10 years, with the last binge yesterday, comes to emergency room after 48 hours of recurrent vomiting and hematemesis. He reports abdominal discomfort that preceded the vomiting by a few days. IV fluid replacement is started while the patient is being transmitted to the emergency room, and while in the emergency room, describes progressive blurring of vision. Over the course of 1 hour, he becomes increasingly disoriented, ataxic, and dysarthric. Which of the following is the most likely explanation for rapid deterioration? So here, the patient had a recent non-alcoholic with a recent binge and worsening. Okay, so it should be an acute condition where the patient is having global confusion, ophthalmoplegia, and ataxia. Okay, and so the answer is going to be Wernicke's encephalopathy. Wernicke's encephalopathy. Okay, Wernicke's encephalopathy. That is very, very important thing. Wernicke's encephalopathy. Wernicke's encephalopathy. Okay, so hypomagnesemia, they should have given about the patient having cramps or reflexes are altered, like that. Something like that should be given. Dehydration, they should have given about the blood pressure. Okay, and after IV fluids it has improved, like that they should have given, so it is not there. Hypoglycemia, they have not given any history about diabetes or any drugs which causes hypoglycemia, or patient has improvement with DNS or dextrose containing solutions is not given, so that is also ruled out. So the answer is Wernicke's encephalopathy. Okay, so this is the answer. Coming to the next discussion, a picture is given like this. Okay, whenever a picture is given like this, okay, and the face, okay, the characteristic face is frontal balding is present. Frontal balding is present along with cataracts. Okay, that kind of face is called as hatchet face. Hatchet face. Along with hatchet face, if a patient has cardiomyopathy, gynecomastia, diabetes with testicular atrophy, then the condition is going to be called as myotonic dystrophy. Myotonic dystrophy. Okay. It is characterized by hatchet face, cataracts, diabetes, testicular atrophy, gynecomastia, and cardiac disease in the form of cardiomyopathy. This disease is an autosomal dominant disease. Autosomal dominant disease, and it has a characteristic feature called percussion myotonia. When you take a knee hammer and if you hit over the hand, there will be a slow contraction and a slow relaxation. Or whenever you give finger and if you they try to hold the hand like this, there will be a uh, difficult in releasing the hand grip. They will not be leaving your hand, they will release slowly. Okay, so this is called as myotonic dystrophy. So myotonic dystrophy, it is an autosomal dominant disease, and it is of two types, MD1, MD2. Okay, myotonic dystrophy type 1, type 2. Myotonic dystrophy type 1 is also called as Steiner disease, whereas MD2 is also called as progressive myotonic myopathy. Progressive myotonic myopathy. Now, this is going to have a more severe course of disease. This is going to have a mild course of disease. This is due to involvement of DMPK1 gene. It is due to involvement of ZNF9 gene. Okay, and this is a trinucleotide repeat disorder, and the trinucleotide repeat which is present is going to be CTG. CTG repeats. Trinucleotide repeat disorder, the repeat is going to be CTG, and what you're going to do is you're going to go for a EMG, electromyogram. Okay, in electromyogram, what is going to happen is there is going to be burst phenomenon. Okay, what burst phenomenon? There is going to be frequent myotonic burst will be there. That indicates the muscle activity. Myotonic burst will be seen. Okay, and that is the feature. Okay, that is the feature. And coming to the question, a 32-year-old male patient presents to your office with complaints of muscle stiffness. After clenching the hands, they open slowly. There is going to be bilateral facial weakness and frontal balding. On tapping the thenar eminence with a reflex hammer, he has a prolonged and involuntary contraction of the thenar muscle. EMG shows small motor units with spontaneous activity with a waxing and waning quality. Which are the following about the genetics of this disease is true? So coming by the order, autosomal dominant condition, but here it is given autosomal recessive. Okay, that is very, very important. Okay, that is very, very important thing. Then second important thing is SOD gene mutation is not associated. Okay, so it is associated with DMPK1, and it is associated with very importantly ZNF in patients with type 2. Then it is a trinucleotide repeat disorder. Trinucleotide repeat disorder. And what trinucleotide repeat we are going to get here? It is going to be our very importantly CTG repeats. Okay, CTG repeats. Can you tell me what is the GAA repeats? GAA repeats. Friedreich's ataxia. Excellent. Friedreich's ataxia. Okay. Friedreich's ataxia. So that is going to be our GAA repeats. Okay. GAA repeats. Very good. Okay. Now, then the next one is going to be our chromosome. Okay. Chromosome. If you take the chromosome, okay, there are two chromosomes are associated with our myotonic dystrophy. Type 1, it is associated with chromosome number 19. And type 2 is associated with chromosome number 1. Okay, so this option, if you go, this looks correct, and this option, okay, is partially wrong, because the most common variety is, sorry, I have written here chromosome, this is chromosome number 3, and this is going to be chromosome number 1, and this is the most common condition. Most common condition. Okay, so this is chromosome number 3, this is chromosome number 19. Okay, and here they have given chromosome number 1. Okay, so any other disease which we'll see later, we associate with chromosome number 3. Any disease you know which is going to be a very good. So von Hippel-Lindau is also chromosome number 3. Von Hippel-Lindau renal cell carcinoma is associated with chromosome number 3. Okay, so that is very, very, very important thing. Okay, so you remember this repeats, that is very, very, very important thing. Okay, very, very important thing to know. So this is about our myotonic dystrophy, and remember the answer is going to be CTG repeats. Okay, and the chromosome number here is 1, and here is 3 and 19. Okay, 3 and 19. So this is very, very important thing to note here. Very, very important thing to note here. Okay, then coming to the next topic, which is going to be involuntary movements. Okay, so what we saw in Parkinson's disease is hypokinetic disorder, whereas what we are going to see here is hyperkinetic disorder. Hyperkinetic disorder. Okay, so tremors. Tremors are involuntary movements. Okay, these are going to be of two types. The patient having tremors at rest and at action. At rest, it is present, it is Parkinson's disease. And this rest tremors improves on action. There is another one condition which is going to be again a rest tremor, which is called as rubral tremor or red nucleus involved tremors. These are also resting tremors which worsens on action or which increases on action. Okay, coming to action tremor. This action tremor is going to be more posture specific. Posture specific. It is due to mutation, and the mutation which is associated is called lingogene mutation. Lingogene mutation. That is essential tremors, where from childhood they will have tremors of no reason. Okay, they will have tremors which for which there is no definitive reason. Okay, that is called essential tremors. Whereas physiological enhanced tremors, physiological enhanced tremors. Okay, physiological enhanced tremors are going to be associated due to a pathology of normal physiological condition or normal physiological phenomenon. For example, hyperthyroidism. Hyperthyroidism, whenever the patient is in stress, okay, those times the tremors will increase. When you tell to write something as a punishment, they have increase in tremors. That is called physiologically enhanced tremors. Essential tremors is from childhood they will have tremors. Okay, and cerebellar tremors. Cerebellar tremors are going to be tremors due to cerebellar disorder, and it is usually unilateral or bilateral. And if you see this cerebellar tremors, they are increased on reaching the target. The patient will have tremors, and as they reach the target, the tremors increases. Okay, so that is going to be cerebellar tremors. Okay, cerebellar tremors. So for this, you have a circle drawn called Archimedes spiral. Whenever a patient with the essential tremors, if you tell them to draw a Archimedes spiral, they will draw like this. That is called Archimedes spiral. So this is the different kinds of tremors, and you will differentiate the tremors like this. Whenever on reaching the target, the tremor increases, then it is going to be mostly cerebellar tremors. Okay, cerebellar tremors. That is very, very important. Coming to the next involuntary movement, we have three important involuntary movements. The first one is going to be chorea. The second one is going to be hemibalismus. The third one is going to be athetosis. Okay. Chorea. This is a repeatedly asked question. The lesion is in caudate nucleus. This is a rapid, involuntary, non-stereotypical. Okay. Non-stereotypical means it's not same movement again and again. Okay. Or same kind of movement again and again. Okay, and it is semi-purposeful, or it is also called quasi-purposive. That is when it is seen as if the patient is going to go for some purpose, he is going to do something, which is a dance-like movement, more on distal and also in proximal muscles. Okay, so it is a rapid involuntary movements, okay, which is going to be like this. Like this. This is called chorea. The lesion is in caudate nucleus. Whereas hemibalismus, the lesion is in subthalamus nucleus. This is also rapid, involuntary, non-stereotypical movements, non-purposive movements, violent flinging actions. Okay, violent flinging actions. Violent flinging actions. Like this. Okay, violent flinging actions more on the proximal. Okay, more proximal. Whereas athetosis, the lesion is in putamen. This is a slow, involuntary, non-stereotypical, non-purposeful movement, which is writhing-like movement, like a snake, writhing-like movement, writhing like slow movements. Okay, like a writhing of a snake. Okay, like writhing movements. Okay, so this is going to be not writing, writhing. Okay, writhing movements like a snake. The lesion is in putamen. Okay, so this is about your thing. And one more thing about your um, essential tremors is these essential tremors are going to be worsening on action. That is very, very important. Okay, worsening on action. And one more thing about your essential tremors I want to mention here is alcohol improves the tremors. Alcohol improves the tremors. Okay, alcohol improves the tremors. Okay. So coming to the question here, an individual in her 60s presents with a tremor. Out of the following characteristics, which one would be more indicative of essential tremors compared to Parkinson's disease? The individual in her 60s, out of the following, which one of the following is more indicative of essential tremor as opposed to Parkinson's disease? Okay. So the patient with essential tremors, what characters is present? They're asking. So the patient at rest, there is no tremors. Okay. Only when they do a target, okay, when they reach the target or all along the movement, they are going to have tremors. So this is ruled out. Alcohol improves the tremor. So this is ruled out. Usually essential tremors or for that reason, even physiologically exaggerated tremor is usually bilateral. So that is also ruled out. Okay. Tremors worse when the arms are outstretched. So it is an action tremor or a position tremor. Okay. So that time the tremor worsens. So the answer is going to be 4. Okay. So this is about our involuntary movements, hyperkinetic movement disorder. Hyperkinetic movement disorder. Okay. So with this, we are finishing the question and coming to the next part of our discussion, which is going to be headache. Okay. Headache. So whenever they give headache, okay. So there are two types of headache: primary headache, secondary headache. Primary headache, the cause is not known. Secondary headache, infections can be there, vascular causes can be there. Okay. Whenever that headache is given with autonomic features, autonomic features, okay, then we have 3 options. The first one, cluster headache, paroxysmal hemicrania. Third one is SUNCT. So usually in our class, I used to tell it is going to be Vijayagant symptoms. Vijayagant symptoms. So what are the Vijayagant symptoms the patient is going to have? The patient is going to have flushing, tearing, rhinitis, increased sweat can be there. Okay. So these are going to be our patients with autonomic features. Whenever similar headache without autonomic features is there, then it is going to be trigeminal neuralgia. Trigeminal neuralgia. Okay, trigeminal neuralgia. Okay. So what are the characteristics of this headache? Okay, characteristics of this headache. Okay. So I will finish this one and I will come back again there. Whenever you have a trigeminal autonomic cephalgias, along the trigeminal nerve, autonomic features with headache will be there, and these can last for seconds to minutes. Okay, this can last for seconds to minutes. Okay, whenever they last for seconds to minutes, and the each headache lasts for 300 seconds. 300 seconds. And in a single day, the patient will get 100 to 200 episodes. 100 to 200 episodes. Then it is called as Shunt. Whenever a patient has episodes lasting for minutes, that is 30 minutes around. In a single day, the patient is going to get around 50 attacks. Okay, then it is called as paroxysmal hemicrania. Paroxysmal hemicrania. Whenever a patient has headache lasting for hours, okay, so they have headaches for 3 hours, okay, and in a single day they get 8 attacks, then it is going to be our cluster headache. Cluster headache. So we have three types of headache: cluster headache, paroxysmal hemicrania, and shunt. Okay, so having copied this, we'll come back here. So we have cluster headache, paroxysmal hemicrania, and shunt. Short-lasting unilateral neuralgiform headache with conjunctival tearing, injection and tearing. Okay, conjunctival redness and tearing. Okay, so if you take this cluster headache, this cluster headache is more in boys. Whereas if you take paroxysmal hemicrania, this paroxysmal hemicrania is more common in males and females at equal proportion. Okay. Now, as I told you previously, the duration of cluster headache somewhere around 3 hours. Paroxysmal hemicrania, it is around 30 minutes. It is going to be 300 seconds. Okay. So in a single day, here you get 8 attacks, can get maximum of 8 attacks. Here you can get 20 attacks. Okay, up to 50 attacks. Here you can get 200 attacks. 200 attacks. 200 attacks. Okay. Then alcohol. Alcohol worsens cluster headache. Alcohol worsens cluster headache. Okay, alcohol worsens cluster headache. Then treatment. The treatment of cases with the cluster headache is going to be oxygen, which is 100% oxygen given at 12 liters to 15 liters. If that is not in the option, the next option is going to be sumatriptan. Whereas paroxysmal hemicrania, we don't have any specific treatment option. Whereas in shunt, you can go for IV lignocaine. Right? IV lignocaine as a treatment. Prophylaxis, here it is verapamil, and here it is indomethacin. That is very, very important. Indomethacin. That is going to be very, very important thing. Indomethacin. Okay. And here not much prophylaxis is useful. Okay. There are drugs like topiramate can be used, but not much useful. Okay. And all these headaches coming under tag will respond to indomethacin. So these headaches are also called as indomethacin responsive headache. Indomethacin responsive headache. Okay. Coming to the question. A 30-year-old male patient, 6-month history of migraines affecting frontal and retroorbital region. So 6 months history of migraine, thought to be migraine, and frontal and retroorbital region on the right side. He denied experiencing periods of free of discomfort. The pain of migraine is moderate intensity of 5/10 and intermittent episodes which are very intense reaching 9/10 severity. In addition to migraine, he describes what appear to be right-sided conjunctival injection and lacrimation. Which of the following is most likely to provide diagnostic assistance? Which of the following can provide diagnostic assistance? What can be the answer here? Yes, we will try to rule out. Okay, we will try to rule out. So, high flow oxygen. We definitely don't know whether it is a cluster headache. Okay, so high flow oxygen can give relief, cannot give relief. Based on that alone, we cannot diagnose the disease. LP. This patient has 6-month history of headache, okay, and the patient had no features of meningismus or neck rigidity or meningitis. So lumbar puncture is not useful. MRI brain you can do if you suspect any structural lesion in the brain. But here, based on the history, there is no evidence of structural lesion in the brain. And there is right-sided conjunctival injection and lacrimation, which tells that the features are more towards TAC. So MRI brain. Okay. And when you give a trial of indomethacin, the patient is responding to it, means then it is going to be a TAC. So more appropriate answer here, it is going to be trial of indomethacin. So one person have answered MRI brain. For example, if you do MRI brain, and if MRI brain is normal, whether it is going to be diagnostic in this patient? No, right? So MRI brain is not going to be diagnostic for this clinical feature. Rather, if they give a 30-year-old male present to a clinic, denied features of pain-free discomfort, and the patient has a intensity of severity reaching 9 by 10 without right-sided conjunctival injection and lacrimation. Which of the following statement is more likely to provide diagnostic assistance? Then what should be the answer? More specific for paroxysmal hemicrania, but all the three conditions will respond. More specific for paroxysmal hemicrania, but all the three conditions will respond. TAC is trigeminal autonomic cephalogyas. Trigeminal autonomic cephalogyas. Clear? Trigeminal autonomic cephalogyas. Clear? Can have. See, there will be multiple episodes of headache. There can be continuous headaches, 3 hours, few minutes of relief, 3 hours, few minutes of relief. They can have up to 8 attacks. It doesn't mean that he should have 8 attacks. He can have up to 8 attacks. Okay. Okay. So we'll clear the doubts towards the end. Okay. Towards the end, we can clear the doubts. Coming to the next discussion. Okay, next discussion, which is going to be migraine. Migraine. So migraine, there are two types of migraine: classical migraine, common migraine. Common is more common. Classical is less common. What is classical? Aura present, common aura absent. So whenever you have a patient coming to you with migraine, the migraine patient to be diagnosed as migraine if he has more than 5 attacks, history of more than 5 attacks. The headache lasts for 4 to 72 hours. 4 to 72 hours. The headache lasts for 4 to 72 hours. And I call this headache, and I have told you this headache is a puma headache, which is pulsatile headache, unilateral or sometimes bilateral headache, but more unilateral headache, moderate to severe intensity, associated or aggravated by movement. Movement aggravates. And this headache is associated with nausea or vomiting, photophobia or phonophobia. Nausea or vomiting, photophobia or phonophobia. Okay. Whenever it is present, then it is going to be migraine. For migraine, there are a lot of variants of migraine is there. Lot of theories behind migraine is there. What is the theory which is the latest accepted theory I have told you? Can you recollect? Can you recollect the latest accepted theory? It is cortical depression theory, right? Cortical depression theory. That is going to be the latest accepted theory. Latest accepted theory. Okay. So now there is a criteria called Midas criteria. Now coming to the treatment of migraine. So whenever you plan treatment for a patient with migraine, the treatment is NSAIDs whenever it is a mild headache. Whenever it is more severe, you can go for sumatriptan. Triptans can be given. 5-HT1BD agonist. 5-HT1BD agonist. We have rizatriptan, elatriptan and all. And we also have CGRP analogs and monoclonal antibodies, right? Calcitonin gene related peptide associated drugs are there. Okay. But coming to prophylaxis, whenever your acute therapy is unsatisfactory or patient had recurrent episodes, then you have to go for prophylaxis. When you will go for prophylaxis, whenever a patient has a single attack lasting for more than 2 days or more than 2 attacks in a month. A single attack lasting for more than 2 days or more than 2 attacks in a single month. Okay, then you will go for prophylaxis. Okay, so prophylaxis, we have lot of drugs. Okay, so you can remember A, B, C, D. A for amitriptyline. Amitriptyline can be given in patient with depression. In your question, patient with depression, you can give. It is contraindicated in patient with mania and contraindicated in patient with constipation. Then next is B, beta blocker, propranolol. It is given in patients with hypertension, but should not be given in patient with especially asthma. Then C, calcium channel blocker. The calcium channel blocker which is used is going to be flunarizine. It can be given in patients with hypertension. Then anti-epileptic drug, the drug with highest efficacy among the anti-epileptic drug is going to be valproate. Then you can also try topiramate. These are few drugs used in prophylaxis of your patient with migraine. Okay, coming to the question. A 16-year-old girl diagnosed with migraine headaches. She has identified some triggers and made lifestyle changes, but still has 14 headaches per month. Appropriate long-term management might include a prescription for daily use of which of the following medication? Migraine headache, triggers are there. She made lifestyle changes. 14 headaches per month is there. So definitely she might require prophylaxis. Appropriate long-term management might include the daily use of which of the following medication. So here it is going to be amitriptyline. Okay, tricyclic antidepressant, amitriptyline. Tricyclic antidepressant, amitriptyline. So that is going to be the answer. Okay, so you know how to interpret the question. Okay, so that is very important. Okay, and if they are going to ask you, so instead of amitriptyline, they are having uh, flunarizine, and patient has a history of hypertension. What drug you will give? Patient is having hypertension, then what drug you are going to give? You're going to go for flunarizine. Okay, instead of long-term management, short-term headache, then what is your answer? Short-term headache, then it is going to be sumatriptan. So the same question, if you change the words, the answer is going to change. Okay, so if in the same question they have topiramate and they have given obese patient and long term, what should be the answer? You know, I have told you topiramate causes weight loss, right? So topiramate, when it causes weight loss, the answer is going to be topiramate. Yes, yes, very good. Okay, so this is how you will interpret the questions. Okay, this is how you will interpret the question. This is how you have to channelize your uh, knowledge whenever you have any kind of clinical questions or any factual questions. Okay, so this is very important. Okay, so this is the most important thing about headache and migraine. Definitely you have to read migraine and go to exam. Okay, coming to the next topic, which is going to be Guillain-Barré syndrome. So you know Guillain-Barré syndrome, now we had an outbreak in Maharashtra, in Pune, where there was an outbreak of Guillain-Barré syndrome. So this might be an important topic for exam because there was an outbreak, right? Okay, so coming to Guillain-Barré syndrome, which is called GBS. Okay, GBS. There are different types of. So the please note down the doubts. Okay, so towards the end of the session I will discuss the doubts, because sometimes it might clear the, or it might affect the flow of the class. Okay, so definitely I will tell you, just write down, we have a separate session of doubt clearing. So towards the end I will definitely discuss the doubts. Okay, one second, there is some problem in the video. One second. Oh, yeah. Yeah, okay. So Guillain-Barré syndrome. So Guillain-Barré syndrome is a wide term where we have AADP, Aman, Amsan, Miller-Fisher syndrome. So if you take AADP, it is less than 4 weeks duration, and the antibody which is associated is going to be GM1 ganglioside antibody. If you remember, we have discussed GM1 ganglioside antibody. Aman, it is acute motor axonal neuropathy. AMSAN, acute motor sensory axonal neuropathy. So here it is GD1A antibody, and AMSAN has no antibody, and Miller-Fisher syndrome has GQ1B antibody. GQ1B antibody. Okay. Now, what is the most common infection? It is enteric infection, and never ever forget this Campylobacter jejuni. Don't forget Campylobacter jejuni. Okay. It can also can occur after vaccinations also. Sometimes even after infections like Zika virus infection, COVID vaccination, rabies vaccination, it can occur. Okay. The most common and the first clinical feature what the patient feels is rubbery feel of legs, followed by the patient has absence of ankle reflex. Absence of ankle reflex. Then what you're going to do, you're going to go for a CSF analysis, and the CSF analysis usually it will be done at the end of first week. And what you get to see is, you get to see albuminocytological dissociation. Albuminocytological dissociation. That is, the albumin will be more and the cell count will be low. And always remember 3 A's, okay? It is acute. AADP is acute. Ascending weakness. Areflexia will be there. Very, very important. Ascending weakness. If you see the word Guillain-Barré syndrome, most of the time in your exam. Okay. And one more thing I want to say here is, it is going to be a peripheral neural demyelinating disorder. So a patient is going to have bilateral element type of facial nerve palsy. And patient can also have autonomic features. Autonomic features. Braditachy can be there. That is also what important clue for your exam. And you go for a nerve conduction study. I have taught you the nerve conduction study in a detailed manner. Okay, detailed manner we have discussed. Okay, so what are the components of your nerve conduction study? Latency and velocity and compound maximal action potential. So what happens to the latency? You're going to tell me what happens to the latency? The donkey story we have discussed, right? The latency is going to be yes, very good. Latency increases, velocity decreases, CMAP is going to remain normal. Okay, CMAP is going to remain normal. Okay, and Miller-Fisher variant. Miller-Fisher variant is a triad, right? Triad. What is the triad? It is going to be characterized by sensory ataxia, ophthalmoplegia, and areflexia. What is the treatment? Whenever you plan treatment, the first 4 weeks is the ideal time for treatment. In that 4 weeks, the first 2 weeks is the best time to treatment. Okay, so the best time to treatment is 2 weeks. We have 2 options here. One is IV immunoglobulin. The next option is plasmapheresis. Both are equally efficacious. Both are equally efficacious. Then steroids have no role of treatment. Steroids have no role of treatment. If it is more than 4 weeks and the patient had or having a delayed holding of neck or improper holding of neck, the neck falls back, or patient has a poor respiratory effort, or whenever the patient is having a single breath count of less than 10, and during the single breath count patient is having cough. If these clues are given in your question, then you have to put the patient on mechanical ventilation. Then you have to put the patient on mechanical ventilation. That is very, very important thing. Okay. So this is about Guillain-Barré syndrome. And coming to the question here, which of the following about Guillain-Barré syndrome is false? I'll go from bottom. Anti-GD1A antibody is associated with AMAN. I have discussed this. It is associated. Sensory involvement can be seen in patient. Yes, I told that bilateral rubbery feel of the legs will be there. Bilateral rubbery feel of the lung means the patient is not able to sense the legs. Patient can have bilateral facial nerve palsy, which is of element type. That is also correct. Glucocorticoid is the most effective treatment is wrong. Glucocorticoid is the most effective treatment is wrong. Okay. So this is very, very important thing. Okay. Very, very important thing. So with this, we are finishing Guillain-Barré syndrome and we are finishing the 20th question. So I'll give you 2-3 minutes break. Then again, we will restart. Okay. 3 minutes break. Then we will restart.